Afternoon again. This is Andrew Deep with the Office of Child Development and Early Learning. With me is Lisa Parker with the Office of Child Development and Early Learning as well. And then along with us presenting today are Meredith Matone and Katie Kellum from CHOP PolicyLab. And I'm actually going to start by turning it over to them and allowing them to introduce themselves a little further and start the presentation. And now, Kelly and Katie, you should be unmuted.
Oh, great. Good afternoon. This is Meredith Matone, the Deputy Director of PolicyLab at the Children's Hospital of Philadelphia and the lead investigator on this MIECHV evaluation.
Hello, everyone. My name is Katie Kellum. I'm a project manager here at PolicyLab and have been leading the qualitative component of this evaluation.
Okay, so we're excited to be here with you this afternoon to share with you the findings from the MIECHV evaluation that we have been conducting in partnership with OCDEL since 2011. Today we'll go through some background just to make sure we're all on the same page about the context and sort of motivation for this evaluation. We'll talk with you a little bit about how we designed our evaluation and what the goals were, and then we'll really get into the findings and conclude with Andrew and Lisa sharing next steps from OCDEL's perspective. So as most of you are familiar, the Maternal Infant and Early Childhood Home Visiting Program, or MIECHV for short, was authorized in the Affordable Care Act of 2010. And it was really established to expand the availability and access to evidence-based home visiting services across the country by providing state-focused dollars to grow slots and infrastructure to support home visiting services. In addition to scaling up services, the legislation also required several evaluation activities. So the local implementing agency benchmarking is one example of evaluation requirements in this legislation, as is MIECHV, which many of you are familiar with, the national randomized trial for which several Pennsylvania sites were a part. And the other mechanism was a mandated state-led evaluation. The state-led evaluation was often a partnership with an academic partner and was done in collaboration with a HRSA technical assistance provider. And this is the evaluation that we're here to talk with you about. So PolicyLab was the research and evaluation partner to OCDEL to perform the HRSA-mandated state-led evaluation. And so just a quick update on PolicyLab. We are a center of emphasis within the CHOP Research Institute. Our mission is really to inform policy and practice change through stakeholder-engaged research, and this evaluation is a terrific example of our model. And we're really grateful that we have almost a decade-long partnership with OCDEL around home visiting evaluation and implementation support. So I'll transition to chatting with you about our study design and aims. So as many of you know, the 4 models that were implemented under MIECHV in Pennsylvania have a rich history of being rigorously assessed and have proven that they can achieve positive outcomes. And therefore, our evaluation really, it was not necessary for us to continue to provide evidence to sort of prove that these models can work, but rather we took the approach of assessing effectiveness. And what effectiveness means in an evaluation context is really understanding the real world impact following dissemination. And so now that we've grown these programs and they're being implemented and scaled up within the state, really checking up on them to understand how implementation is going and what are the outcomes now that we've sort of sent these programs out to communities with varying staff and clientele and community infrastructures. And so with that in mind, our aims, which we developed in partnership with OCDEL, were to understand whether expanding the number of families enrolled in home visiting programs and strengthening the early childhood system in Pennsylvania contributed to improved maternal and child health outcomes for communities and targeted populations within the state. Also to explore the contextual factors shaping implementation, because we know that local context matters so much in determining sort of the success of a program at an individual LIA level. And lastly, to understand key stakeholder perspectives on the barriers, facilitators, and motivating factors that influence families' decision to enroll and engage in programs. And so to achieve these aims, we used what's called a mixed methods evaluation design, meaning we used quantitative data to understand and drive our assessment of outcomes, so related to aim 1 here. And then for aims 2 and 3, we used what's called a qualitative approach, where we did site observation, surveys, and interviews to really understand the context and motivation from key home visiting stakeholders. On the quantitative side, we used what's called a quasi-experimental design, which really just means that we matched home visiting mothers and compared them to women in their communities who were similar in terms of demographic and health-related factors, but who did not receive home visiting services. And so it's not a randomized trial, which is sort of a full experiment, but one in which we sort of are able to create the environment that is similar to a randomized control trial, but observe outcomes on a wider number of folks. We used a linked administrative data set to do this, and so we started with home visiting program data from the LIAs, and we were able to link that to birth certificate data, welfare data, and Medicaid data from the state to create a really rich resource of information from which to observe not only client outcomes, but risk factors and community level outcomes that may drive outcomes. And so what you'll see here is for each of the 3 programs that were included in the quantitative analysis, you'll see the number of clients that we were able to observe and include in the evaluation. So for NFP, we had about 8,700 clients, MIECHV clients that were included in the evaluation. For PAT and EHS, we had roughly about 850. And here you'll see the demographics of the client population. In general, and this will be sort of no surprise to most of you, that the client population for home visiting services in Pennsylvania tends to be low income, younger, unmarried mothers. You will note here that there are some different demographics by program model. And so Nurse Family Partnership in serving first-time mothers tends to have the population that is youngest and the highest percentage of unmarried mothers. You'll note some of the demographic differences with PAT and EHS as well.
So as Meredith mentioned, an innovation in PolicyLab's evaluation approach was the inclusion of a robust qualitative component. We conducted more than 150 interviews, which is an incredibly large number for a qualitative study. And instead of just talking to home visitors and program administrators, we also chose to interview families so that we could understand both the delivery and the receipt of home visiting services. And in order to get a sample of local implementing agencies that really represented all these important features of the 38 MIECHV-funded sites, we were thoughtful about choosing sites that had a very broad representation of that geographic location, population density, and also program size. And then obviously, as you'll see here, the program model. So for the qualitative component, we were able to sample agencies implementing all 4 program models. And here are the demographics for the qualitative sample. So as I mentioned, this is representing 150 interviews, and that represents, us speaking to as many staff and clients as possible. Sites really helped a great deal to connect us with clients who were interested in participating. And we expect that the size of certain programs impacted how many staff and clients were available to interview. But overall, we do want to highlight that we had great representation from each model and also rural and urban sites. So I want to speak a little bit more about what our data collection process looked like. To conduct those interviews, we developed an interview guide for each stakeholder. So for administrators, as well as home visitors and parents engaged in home visiting. And we worked with program model leadership, as well as folks at OCDEL, to really shape the questions in order that we would gather information that was important to your own research goals, and also use language that was appropriate. And these guides contained questions related to availability of and collaboration with other programs in your geographic area, as well as the role and training and curriculum for home visitors to use. And then also clients' personal goals, their relationship with the home visitor, and their perceived impact of services. So when it came down to analyzing those data, we used something called a modified grounded theory approach, which basically means that there were some themes that we knew we wanted to explore from the beginning. So those included the aims that Meredith referred to earlier about sort of the contextual factors shaping implementation. We were also very aware of the Home Visiting Applied Research Collaborative's research priorities and wanted to include them in how we looked through all of that interview data. And then the modified piece is that we were looking for themes that might arise sort of naturally from the interviews that we might not have been expecting to see initially. So all interviews were coded with a full set of themes in mind, so we could get a full spectrum of thoughts, again, with all stakeholders represented, before we could then review each theme more closely to see how people were thinking about it.
And so now we'll jump in and spend the majority of the time here talking through our findings. And we'll go over sort of 4 buckets of findings with you today. One is around enrollment and growth of MIECHV services across the state. Then we'll talk about findings for high-risk subpopulations of families that were of sort of priority to OCDEL, and transition into talking about implementation strategies, and this is an example of a theme that emerged sort of naturally from the interviews that we did with program staff. And lastly, we'll talk through 2 target outcomes for all program models. So first, enrollment. So the first very basic question that we wanted to know and understand is, what was the impact of MIECHV dollars on growth of services to eligible families in the Commonwealth? And what we found was that on average across all program models in the years following MIECHV, we've seen 400 additional families served each year. So not an insignificant amount. This map here gives a little bit more information and a little bit more sort of detail about where those dollars went and where program services were most expanded. This is penetration of home visiting services within a zip code. And what we mean by penetration is a ratio of home visiting served mothers to eligible women in that zip code. And what this map is showing is the percent increase or decrease, so the percent change between 2012, which is really when programs were sort of rocking and rolling with the new MIECHV dollars, through 2014. And the darkest blue represents sort of the highest penetration, and that light blue represents a decline in penetration. And so I think it's interesting to take a look at this and see that there are definitely sort of bands and clusters of strong growth in penetration of home visiting services, and it's pretty remarkable to achieve a 5%, for example, 5% growth in penetration when we think at a zip code level and just the sheer number of families in a zip code level. So I think this really sort of is a tribute to the hard work that is done at an LIA level to integrate within a community, and we know how hard recruitment is, and I think this map is really a nice sort of testament to that.
And Meredith, referring to that sort of growth and the number of families that were recruited into programming, we also wanted to, from the qualitative perspective, use our interview data to really explore what motivated parents to join. And in that exploration, we sort of took away some parent-focused, child-focused, and program-related factors. So in interviews with parents, we learned that home-visited families most frequently participated because of their own desire to gain access to information and resources as parents. So particularly for parents who were first-time parents, those folks felt really uneasy about pregnancy and parenthood, and were motivated to join because of the sense of assurance that they would acquire from having an expert closely involved throughout the growth of and development of their child. For parents also who had a specific concern about their child's development or behavior, the primary motivator for them seemed to really be about getting that additional support for that primary concern that they had with their child. And then I also just want to highlight broadly that parents were really citing the general emotional support and friendship that the program offered their family. So that's not to be undercounted. I think that's really significant as well. And just a note, so for the qualitative portions, I will be putting up quotes on the screen. I won't be reading through them, but you're welcome to take a look at them. So for child-related motivators, clients were initially attracted by programming for the help it offered academically and socially preparing their children for school. Parents valued their child also having the opportunities to interact with another adult on a regular basis that wasn't a family member to really help them get acclimated to be interacting with other children and adults in the school environment. Program factors also played a role, and parents described how hearing about home visiting from friends was sort of a primary motivator for joining and helping them learn about and become interested in home visiting services. And then lastly, as you might, as is to be expected probably, parents also really described how the services being free and also being delivered in the home were just made it so convenient that it was easy to say yes to this opportunity. So on this slide, we're just sort of summarizing for you some potential takeaways. You're welcome to think about sort of what those implications for your practice might be from those findings. But based on these information, we really felt it was important to highlight the ongoing support programs offer, particularly related to healthy development and school readiness. And then also thinking through the opportunities to explore referral relationships with other services who are working with families that are identifying developmental concerns, for you to sort of get in touch with those parents who are seeking that support. And lastly, engaging current clients in recruitment efforts, either encouraging them to use word of mouth or posting on Facebook, could really help new families get informed and excited about home visiting.
Okay, so now we'll transition to talking. We have 3 subgroups of high-risk families that we want to share some information with you about. The first is children with special health care needs. the reason that we were interested in this subpopulation as a priority population was really twofold. One, there was an issuance of federal guidance between the Departments of Education and Health around making more explicit infrastructure and connections between MIECHV and early intervention. And also, we had heard in some of our interviews about the relationship between MIECHV programs and early intervention, and really just wanted to understand what was the landscape of home visiting services being provided to children with special health care needs, and really what proportion of families served do have a child who's been diagnosed with either a growth or a developmental concern. And so what we found across the state was that roughly a quarter, a little less than a quarter of all Medicaid-enrolled children in the state are diagnosed with either a growth or developmental delay by age 4. But when we looked at home visited families, and here I show you the number for NFP, but it's comparable for other programs, that we see a higher proportion of home visited families have a child that's diagnosed with a growth or developmental delay by age 4. And I think some of that makes sense when we think about the fact that programs are targeting high-risk families, but that also families who suspect or have a concern about a child's growth and development are more likely to seek out home visiting services. But I do think it's important to note that as many as 1 in 3 children by age 4 will actually have received a diagnosis for a growth or developmental delay. The 3 most prevalently diagnosed special health care needs were developmental delay, growth delay, and sensory delay. And the other thing that I wanted to sort of share about this was that there was wide county-level geographic differences in the prevalence of early childhood special health care needs, wherein rural counties in the state overall seem to have a higher proportion of children diagnosed with special health care needs. And that may reflect sort of differences in both access and sort of screening and diagnoses to healthcare services in rural communities, or the sort of importance of the developmental screens that are being conducted by programs in those communities. And so here we just wanted to share both the sort of overall proportion of home visited clients that were diagnosed with each one of these conditions, as well as the average age of first diagnosis, which I think is important in thinking about the overlap with when diagnoses are occurring, and therefore when child symptomatology is occurring, that really does overlap with the time period in which families are receiving services.
So we also looked at this in the qualitative data and explored sort of what families and staff had to say about collaborating with early intervention and home visiting. So staff described really a mutually beneficial relationship, a referral relationship, and talked about how collaborating on service delivery to specific families sort of enabled them to shape the goals that they were working on with families, and also really help them sort of shape the information that home visitors were giving because of the things that they were sort of learning from the additional info that the early intervention folks had on children. And then also we just wanted to highlight some potential issues that came out of the interviews. Were definitely some families felt overwhelmed by being involved in multiple services and also had trouble sort of keeping track of the different ways they were expected to engage with those services. And this might not come to as a surprise to you, that certain times sort of because for the home visiting services, parents were expected to sort of take a more active role. It was confusing to switch between that role and the role where an early intervention staff person might be more directly engaging just with the child during sessions. And here are a few quotes that sort of just demonstrate the words that people had to say about these issues and also strengths.
So the second high-risk subgroup that we explored were looking at home visiting clients experiencing maternal depression. We know that this issue is receiving quite a bit of attention sort of programmatically and programmatic guidance sort of federally, and also within each home visiting model. I feel like there's been also a lot of movement to address maternal depression, and it felt like a priority to take a look and understand how mothers who may be experiencing maternal depression, and not just postpartum depression, but sort of depression symptomatology more broadly, in their time in the program may be faring in terms of their outcomes. And what we found is that of clients, comparing clients who have been diagnosed with depression to clients who have not been diagnosed with depression or anxiety, which sort of make up this category of mood disorder, that those with diagnosed mood disorder are achieving positive outcomes, but not to the level of mothers without diagnosed mood disorder. And so the two outcomes that we looked at here were receipt of recommended number of well-child visits for their infants, and mothers without mood disorder, you'll see here 43% of them received the recommended number of well-child visits for their children versus 36% of mothers of mothers with diagnosed mood disorder. And similarly, in looking at prenatal smoking cessation, we saw that mothers with mood disorder were less likely to achieve prenatal smoking cessation. I think what's important to note here is that we know that the supports that these mothers are receiving in the home visiting services are very helpful, and that likely what is happening is that the outcomes that we observed here would likely have been much worse for these families had they not been enrolled in home visiting services. And so we know that home visiting services are a critical support, not only in identifying, playing a really important role in identifying depressive symptomatology, but also sort of providing services either directly or indirectly to address maternal mood disorder issues, either depressive symptoms or anxiety symptoms. But that it does seem like there is potentially an opportunity to strengthen either sort of collaborations or service provision to these mothers, because there is a slight disparity in the achievement of outcomes for mothers who have, like I said, been diagnosed with mental health concerns.
So lastly, we're going to take a moment to look at sort of how home visiting is operating for rural families in particular. And this is something I sometimes forget because I'm sitting here in Philadelphia, so I think it's helpful to just remind ourselves what a rural state Pennsylvania is. And just because of our interviews really having intentionally purposed both rural and urban populations, we wanted to take this opportunity to broadly understand how home visiting programs are operating in these rural areas, both the barriers that might be unique to those populations and the ways that home visiting programs are adapting to meet those challenges. So this is a little bit of a busy slide, and I encourage you guys to take some time later to look at all the information on it. But I did want to just say broadly, we've organized our interview content around the community capitals framework, which really lays out all the necessary parts or capitals in a healthy community ecosystem. So for example, financial capital, so might be something that comes to comes to mind very quickly, but also other aspects like political capital, social and human capital, and also the unique cultural capital that exists within each individual community. So this framework rests on the idea that investment in one capital sparks a process of assets building that increases overall opportunities and well-being in a community. And we thought it was really appropriate to use in the context of how home visiting is operating and might be impacting individual capitals, but also having a larger impact overall. And on this slide, we're sharing the rural-specific constraints that we identified in our interviews with clients and staff. So some might be more obvious, like for natural capital, you see on the list the long and cold winters that could make completing home visits extra difficult. And others, like this one related to financial capital, where there's an increasing need for kinship care because mom or dad is traveling further for employment opportunities, might be more surprising. So those were all things that came out of the interviews, and we wanted to share with you to sort of hear from you about whether they reflect your own experiences, but also share with you just what other folks are talking about. So in the face of those barriers, we wanted to also explore the ways that programs are sort of adapting to and also just naturally within their own given curriculum are meeting these needs. So several of the adaptations and enhancements that home visitors engaged in may have been focused on improving maternal health through health-specific programming, but also those actions often contributed to improving multiple capitals. So this is also a way that we see how specific acts are sort of operating beyond their maybe primary intention. And I want to share some quotes related to this. And this is a quote from a client talking about group play dates and how they really helped participants overcome feelings of isolation, especially during long winter months. And as I was mentioning, these activities improved social connections and built social capital, but also improved human capital through investing in educational activities for kids. And then this is a real sort of adaptation, since I know that group playdates are sort of built into certain curricula, but this one LIA decided to hire a mental health consultant because of the issues they saw in their client population with accessing mental and behavioral health services. So particularly due to stigma around those issues and also real lack of transportation options, this provided a really great opportunity for their clients to get services that they really needed. And next, we're going to talk about some implementation strategies that, as Meredith said, sort of came out of the data, and we decided to explore further to understand how they were operating and the impact that they were having. So during the evaluation, we noticed that a few sites that we visited, instead of just using one evidence-based model, were implementing two models. And then also noticed that some programs were located and are co-located with a healthcare entity. And we really wanted to see how that worked for them. So first I'll talk about the co-location of two evidence-based models. And this is just using our qualitative data that came from the 4 sites that had co-located models. So from the interview data, we really learned about how it was hard to start a new model, and that when you were starting a new model at an agency that already was operating a model, there were a lot of benefits and sort of ability to jump ahead so that you didn't have to worry about trying to create recruitment and referral relationships where there were none. So there was a real benefit to programs to sort of build their network from something that was already created, as opposed to starting from nothing. It was also really evident that using models that had varied program eligibility both helped the agency by expanding the number of eligible clients that they could recruit from, as well as from a client perspective, really enabling more families to be eligible and giving them the opportunity to engage in these services. Additionally, those model differences related to curriculum really helped families be matched with the curricula that most appropriately met their specific needs. So for instance, you might choose to match a high needs family with a program model that was meeting more frequently than a family that had less needs. There was also a lot of built-in sort of efficiencies to this model, that if you were operating one model, you could very easily sort of add a second model and use similar shared administrative staff, and also any sort of trainings and opportunities that you were bringing to your center or offering one set of home visitors who might be using one curriculum. They could also, the other home visitors using the other model could benefit from those learning opportunities. And we also heard a lot about how home visitors from each model sort of would go to each other for support, and really valued having a slightly different perspective coming from their individual model training. And lastly, there were some really smart ways that each sites that were implementing two evidence-based models thought about how they could use them together. So the one example is about sort of when a high needs client completes model one, they're able to maintain their service, their time in the program by continuing with the second model right after the first.
And so on the quantitative side of things, we were able to take advantage of the fact that we did have a fair number of LIAs that had co-location either physically or administratively with a healthcare entity, to really understand whether or not that co-location conferred any benefits to clients in terms of improved access and receipt of healthcare. So the two metrics that we looked at were receipt of prenatal care and appropriate use of well child visits for home visiting enrolled families. And what we saw among co-located clients was that, as compared to clients who are in LIAs without healthcare co-location, that there was increased use of these preventative healthcare services, both prenatal care and well child visits. I will just note that prenatal care is an adequate prenatal care is a positive outcome for programs, and even clients among non-co-located sites are meeting a great benchmark there at 71% of clients, even at non-co-located sites, are receiving adequate prenatal care. And so in thinking about the high-risk population that you serve, I think that there's sort of kudos to go around for both of these metrics, regardless of co-location, but that we did see a benefit of co-location on access to appropriate preventive care, both for mothers and children. And this was particularly strong for well child visits, which I think makes sense because most of the co-location that's happening is happening with a healthcare entity that is responsible for primary care services in some way, rather than obstetric care. So we did see a stronger program effect there on well child visits that even persisted beyond just comparing clients of healthcare co-located sites to clients of non-co-located sites, but even within co-located sites, clients in those LIAs are performing significantly better in receipt of well child visits than community comparison women. And so I think, in conclusion of co-location analyses, both sort of qualitatively and looking at the sites who use MIECHV to take advantage of implementation of a second evidence-based model, and those who have both physical or administrative co-location with a healthcare entity. In general, co-location is an interesting implementation strategy that does confer benefits both logistically and potentially passed on to clients. And that dialogue among model leadership, LIAs, and other sort of health services, and beyond health services, other community partners about collaboration in consideration of co-location of some sort may improve system integration and family outcomes. Okay, and so the last domain that we wanted to share with you about this evaluation was really looking at two key target outcomes, health-related target outcomes. The first is prenatal smoking cessation. The second is abuse and injury. Prenatal smoking cessation is an important outcome to look at in the context of Pennsylvania, because we are a state with a significant burden of smoking. We know that smoking cessation is so important in thinking about both the health of a pregnancy and also infancy and early childhood health. And it has traditionally been a strong programmatic outcome for programs. And so important for us to take the opportunity in this evaluation to go beyond just looking at outcomes, which we'll share with you, but also use some of our qualitative data to really understand the ways in which home visiting services are impacting smoking behaviors in the family. And we have some exciting information to share with you about this. So overall, we found really positive outcomes for prenatal smoking cessation. For nurse-family partnership, which, as you know, enrolls women prenatally, and so we have sort of the largest client capture for which to look at prenatal smoking cessation among nurse-family partnership families, we saw a 30% reduction in prenatal smoking among clients, which as compared to community comparison women. And that's a very significant finding. And real big kudos because we know that smoking behaviors, particularly smoking behaviors among heavy smokers, are not an easily modifiable health behavior. What we found, in addition to looking at smoking cessation, is we took the opportunity to also look at harm reduction. So looking at the impact of reduced cigarettes smoked rather than just looking at cessation, because we know that from our interviews that a lot of the ways in which home visitors engage with families are to use harm reduction motivational interviewing that really emphasizes reduction if cessation is not possible. And we really wanted to be able to highlight the success and efficacy of that approach. And what you'll see here in this bar chart, blue are the comparison families who did not receive home visiting services, and green are the clients. And along the bottom, you'll see the number of cigarettes smoked in the first trimester. And what this is showing is a reduction in cigarettes smoked by the third trimester. So what I really want to highlight here is this final bar, these final bars which on the right side, which represent the heaviest smokers in the first trimester of pregnancy. And what you'll see is that we had the strongest program impact of reduction in cigarette smoking by the third trimester among our heaviest smokers. And that's not an achievement that should be taken lightly. And we're really excited to share that with you.
So also the interview data that we had enabled us to really hear from clients about how these programs were impacting their thought process on smoking. And that, as Meredith referred to, sort of spanned from cessation, full cessation of smoking, all the way down to sort of just reductions that were maybe not sort of always a measurable outcome, but important progress for families. So we learned more about the successes achieved in reducing second and third hand smoke from the interviews rather than the quantitative data. And for example, clients really started to wear a smoking jacket to protect their child from cigarette ash and residues that might be on their clothing. And they did that only because it was at the recommendation of home visitors. And the curriculum related to these issues provided valuable feedback both to folks who were active smokers, but also to other folks that might not be smoking themselves, but were in social situations where they might have exposure to other folks who were smoking. So this was really important to all clients to be educated about second and third hand smoke and harm reduction strategies.
And we'll end here with talking about our abuse and injury findings. And really what we'll focus in on today is the findings around child abuse prevention. What I'll share with you sort of before we get into the data is that it was important for us to look at this outcome, not only because it is a sort of core tenet of many of the models, and certainly the models that are being implemented in Pennsylvania, but also that from a more national context, there has been a growing number of studies that have been looking at child abuse prevention outcomes of home visiting programs, and particularly abuse in the context of abusive injury. So we're not talking about sort of global maltreatment here, which under the umbrella of maltreatment is abuse and neglect. And we can talk maybe in the question and answer if you'd like a little bit about neglect, because that domain is different. And there are some really promising findings around neglect prevention. But here, so that we're all on the same page, we're talking about abusive injuries, which represent a very rare outcome. So that's the other thing I want to sort of share at the outset. But there have been a growing number of studies that have been looking at home visiting programs sort of post-implementation and scale up. And again, this sort of real world implementation look at these programs, and have found that this outcome in particular may not be as strong as what was found in earlier randomized control trials for these programs. And so it was important for us to take a look at this outcome. And I'll sort of share with you before I show you the data that we did not find a positive program effect on child abuse prevention across the three models that we were able to look at this outcome for. So nurse-family partnership, parents as teachers, and early Head Start. And what we did find was that these across program models, programs were sort of performing similarly, that abuse, as I mentioned, is a rare outcome. We have about 1% of client families experiencing a healthcare encounter for child abuse related injury. And that's consistent across our program models here. And what this chart shows, the bars on the left, the sort of more lightly shaded bars, are the percent of children diagnosed with an abusive injury in a healthcare setting. The bars on the right are the community comparison children. We did find that client children were more likely to have an abuse-related injury healthcare encounter than comparison children. And again, we can talk a little bit about this in the question and answer if you'd like. I think I'm able to share with you a little data on the next slide about why that may be. And I think what we're finding in general is that across the board, across program models, in the Commonwealth, LIAs are enrolling a very high-risk group of families. And I think that in many ways that is a really significant achievement to be able to find, recruit, and retain high-risk families in your programs. And the flip side of that is families are presenting, I think, with a number of, in particular, social challenges that are very high risk and that may require partnerships outside of home visiting to address some of these challenges. And when we look at abuse in particular, we were not able to determine who the perpetrator of the abusive injury was, but I'll share with you, and Katie will talk a little bit more about this, that across the board in our interviews, what was coming up was that it's not the client themselves, so very rarely is the mother the perpetrator of an abusive injury to a child, that what's happening is in the context of complicated and context social circumstances of clients' lives, that abusive injuries are happening in most often in the context of an alternate non-maternal caregiver. And I'll show you on this next slide that when we look at families who where mom has received a diagnosis in a healthcare encounter for intimate partner violence, you'll see that there's at least a doubling up to a tenfold increase in a child abuse outcome among client families where mom has experienced IPV, and IPV with the severity that resulted in a healthcare encounter. And I think this is just one example of the sort of contextual circumstances going on beneath the surface when we look at child abuse outcomes. I think the other component here that both came up in interviews and is consistent with other literature is that programs are doing a really excellent job supporting mom in achieving personal goals around educational attainment and employment. With that, often comes the need for childcare. And in the absence of either availability, access, or information on choosing a safe and appropriate caregiver for your child, I think we sometimes are seeing in the context of some of the qualitative work in the interviews with families, unintended consequences of children being left in childcare arrangements that aren't ideal and put them at risk for child abuse related outcomes. And so the other thing to share about this is again, just to reiterate that abuse is rare, and this is not the most common type of healthcare encounter for injury that client families are experiencing, though arguably it's one of the most important when we think about sort of life course trajectory of health and the sort of health and well-being related sequelae of child abuse, but also to just reinforce to you that we are seeing very consistent among home visiting clients, consistent with the sort of broader child health literature and research, that the most common injuries are what's called superficial injuries. So minor injuries, cuts, scrapes, abrasions, things that you associate with childhood. And these are the most prevalent healthcare encounters for injury that are occurring for client families.
So as Meredith talked about, I'm going to share a little bit of the qualitative data that we have on this topic. And as she alluded to, there are instances that we heard in the interviews about that did not include mothers, but included other partners, and also grandparents, and also child siblings that might have been sort of inflicting harm. So this quote I have up on the screen now is from a mom who's discussing injuries that her son received while spending time with the father who was not involved in services. So I think that's a really interesting and important thing to note around sort of how we think about implementing services and the reasonable impact we could imagine those services have on those parties that receive them, right? So as Mara said, when you're thinking about the context of a family and the importance of childcare options, we have to be thinking about how we're engaging folks other than just mom in information about prevention and attachment with the child. So we also wanted to use the qualitative data to think through sort of what we heard about the program responses. So on this slide, we think about the point at which the program can really take action. And often that's happening after there's an issue that's been identified. So giving parents support after the fact. And as you saw in the previous slide, sort of in the quote, the mom reflecting on the information she got about child protective services. And a lot of that is up to the parent about how they take their next steps and whether they engage in those other supports and community referrals. And also, I did include this quote, I'll just say, to give you a sense that training for home visitors might be different. And you can see here that this home visitor sort of talks about maybe not getting into abuse so much, even if they're sort of seeing it, but focusing more on suggesting that what we're promoting is a healthy environment, and suggesting that the client take the lead on making that happen. So just to highlight that there are issues around training, and each home visitor needing to sort of follow through with whatever steps are outlined if that support is given by their program. We also heard from folks about the more preventative tools they have in their toolkit. So home visitors talked a lot about positive parenting and secure attachment. And from the family side, we heard very strongly that the piece about stress management, I think, really did translate well in thinking about sort of when you need to separate yourself from a situation and give yourself some time to breathe and take a break. So I think parents really appreciated that and felt the relationship that had to discipline and child care. But the other thing just to note from the interviews we did with clients was that a lot of them didn't remember talking about child abuse. So that was a question that was asked of every parent, and some folks many folks actually didn't recall discussing it. And so this might be just an issue with translation, that we're not talking about it in such direct terms as child abuse. But the feedback that we did get from parents was that they did think that this was an important issue for home visiting to address, an appropriate issue for home visiting and home visitors to address. So we sort of wanted to give that feedback to you, that I think we definitely heard the opposite from home visitors, that there might be a sense that this would cause families to be defensive or turn them away. But clients sort of said that we understand that this is an important issue, and we want to learn about it. We also just wanted to say that we recognize there are barriers to engagement. So as I was just mentioning, home visitors did really sometimes question not only whether they should bring it up, but whether they had the impact to change those behaviors if they were seeing situations with sort of maybe more corporal punishment to handle disciplinary issues. And then also with this, we wanted to highlight that even when a parent is sort of open and willing to learn about different strategies, you know, we can only expect the services to go so far, and that you, as you see with this this quote, that a parent is learning about multiple options, but also feeling empowered from their home visitor that there is no right or wrong, and that it's up to her to make those decisions. So, you know, we do recognize that that parents will sort of use the information that is given to them as they see fit.
And so just to summarize that, while we saw no programmatic effect on abuse prevention, we did identify some circumstances and subgroups of clients for which this really does appear to be a really acute issue. And in specific, families with IPV are at very increased risk for child abuse in the Commonwealth. And that, as Katie just mentioned, that the success of abuse prevention, at least from the interviews from home visitors and families that we talked to in the context of this evaluation, really depends on the strength of the curriculum and the degree to which abuse may be sort of explicitly a topic of conversation and in the context of the relationship between the home visitor and the family. The fidelity of the delivery and really the availability of community supports for referral, so that we know in the context of challenging social environments for families that really, for example, in the context of IPV, that the ability of the home visitor to deliver effective curricula around positive parenting practices in the context of an IPV situation really is contingent upon that family successfully engaging in other supports that are going to address that in home environment. Again, this sort of raises the notion of the importance of delivery to caregivers beyond parents, and specifically beyond mom, and the degree to which we're able to successfully engage non-maternal caregivers, or as sort of a proxy, empower moms to make informed decisions about safe childcare arrangements. And lastly, similarly to sort of needed community supports for referral, is really the availability of quality childcare options for families that we are sort of transitioning on to educational and employment attainment. So I know that was a lot of information. I think that does it for us, and we will turn it over to Andrew and Lisa to talk about next steps from OCDEL's perspective.
Yep, we're unmuted, but actually I'm going to go ahead and there's a few questions that I'm just gonna read to you here that you can answer before OCDEL gets started on their piece. So first question was, what year does the study cover?
The study goes from, depending on the analysis, from 2008 through 2014 for some outcomes and 2015 for others.
Next question was a question around the enrollment. So what about the fact and the special healthcare needs? What about the fact that NFP clients are enrolled during pregnancy and usually do not know that their child has a special healthcare need? I guess if it's diagnosed after they exit the program at 2, those items, how was that factored in?
Yeah, so and that analysis was really just sort of observing the sort of diagnostic pathways. Certainly when we're talking about families who are making decisions to enroll based on a concern they have for their child, that we're really talking about EHS, PAT, and HFA. And that for NFP, I think the point is that we did have about half of those diagnoses were being diagnosed before 2 years of age. And so really the point is just that NFP is serving families for whom children are sort of disproportionately expressing symptomatology for growth and developmental delays. And it really was just meant as, for all of that analysis, really just meant as an acknowledgement that home visiting programs in the state are disproportionately serving families for whom there are special healthcare needs. And that those symptoms are likely present during the time that families are receiving services.
Next question was, were the child abuse injuries founded, or did the healthcare visits with injuries represent potential child abuse injuries?
So the data that we used did not incorporate Child Protective Services data. So when we say child abuse, we're not talking about substantiated child abuse. What we're talking about is a healthcare encounter for which abuse was explicitly diagnosed by a healthcare provider, or there was an injury that was deemed to be with high suspicion of child abuse. And this is based on an expert panel of child abuse researchers who have categorized a number of injuries. So for example, a femur fracture for an infant under 1 year of age has an incredibly high probability of being child abuse. And so we used a diagnostic algorithm that was derived by an expert panel of child abuse pediatricians to come up with injuries that were either explicitly diagnosed as child abuse or, as I said, are considered high suspicion child abuse injuries. And the reason that we looked at it in this way rather than looking at child abuse substantiations through Child Protective Services is because this is a bit more of an objective measure. Number one, it's something that we can observe through administrative claims on a whole population longitudinally. And number two, the injuries that we are looking at are injuries that are severe and require medical attention, and so they wouldn't really be subject to bias in the fact that we know that families receiving home visiting services may have more comfort in accessing healthcare services, and so they may be more likely to receive healthcare services, but the outcomes that we're looking at are really outcomes that are not outcomes for which you sort of subjectively receive healthcare. They're outcomes for which healthcare is required for a child, and so it sort of removes that bias. And lastly, we also know that there's a tricky relationship with Child Protective Services and home visiting, and we didn't want to bias our findings in any way by relying only on cases of abuse that receive substantiation, because we know that there are a lot of considerations that go into determining whether or not a substantiation is made. And we didn't exactly know how to interpret what we found, because on one hand, families who are receiving home visiting services may be more likely to engage with CPS because there is potentially that surveillance there. But on the other hand, we know that child welfare workers may be less likely to move forward with a substantiation if they know that there are home visiting prevention support services in the home. And so it wasn't clear what direction that bias was going to go. And so we just moved away from looking at that altogether.
All right. Next question is, were all of the primary caregivers mothers?
So In the qualitative interviews, the vast majority were mothers, but we did have interviews with dads and grandmothers.
Thank you. Is the increase in child abuse report due to increased knowledge and reporting by staff? Somebody asked about the increase in the abuse reporting.
So based on the analyses that we were able to do, it does not look like that. For the reasons I just explained, the severity of the injuries that we were looking at were really not injuries for which the sort of surveillance of a home visitor in the home would have likely impacted healthcare seeking behavior for those injuries. What we also did was do some statistical modeling to try and account for that. So we actually modeled the likelihood of a home visited family to receive health care for non-injury related things. So we looked at the likelihood of a home visited family to use emergency department services versus community comparison families, and we were able to sort of adjust for the higher likelihood and comfortability with healthcare access of home visited families. And we took that into account in our statistical modeling, and it did not change our findings.
Thank you. Is there a programmatic effect on neglect rather than injury? I guess, or is there a programmatic effect on neglect that you found in your evaluation?
So we did not explicitly look at neglect in this analysis. I can share with you some preliminary work that we're doing around infant mortality and looking at domains of mortality that are more neglect and supervision related versus domains of mortality and causes of death that are related to assault and physical abuse. And there we are seeing potentially a programmatic effect on what we're calling sort of supervision and neglect related fatality. And that analysis is ongoing, and we will absolutely keep everyone in the loop as we move that forward. It's very consistent with other emerging research. So for example, there was just a study out of Connecticut Parents as Teachers program that was looking at child abuse substantiations that found a positive program impact of parents as teachers on neglect. They did not find any programmatic outcome on substantiated child abuse, but they did find a significant positive program impact on neglect-related maltreatment, which is very important because when we think about maltreatment and engagement with the child welfare system for maltreatment, 70% of maltreatment is neglect, and physical abuse and other domains of abuse represent a much smaller proportion of maltreatment. And so I think when we also think about, and what we heard in our evaluation around the curricula that is delivered around home safety, parental supervision, and connection to community resources, from a theory of change and a model theory of change perspective, those are all very aligned with neglect prevention, and those are all components of curricula that we found in our evaluation were being delivered strongly, both in sort of self-report by home visitors and also from families, and being able to sort of recall engaging with home visitors around those domains of home environment and home safety that may be most aligned with neglect prevention.
All right, and there's one last question right now around, was race a factor in child abuse healthcare encounters?
No. We know that race is a factor were we to look at substantiation within the Child Protective Services system, which is another reason that we didn't go that route, again, because we know that the pathway to substantiation has some subjective components to it. When we do our analyses, we sort of adjust for and control for race and other demographics. And not only do we sort of do that up front, but in sort of looking after the fact, there wasn't sort of, after we did our modeling, there was nothing that remained as significantly predictive by race.
All right, thank you. And for those who asked, and I sent a chat box to everybody, the recording of today's webinar and the PowerPoint will be available on our website in a few days to be able to download and to watch again if you choose to, or to share. So we're going to go ahead and get started, and I'm actually going to turn it over to Lisa Parker and Katie, if you don't mind giving us keyboard and mouse control so we can move it forward, or if you just want to move it forward when we say either way, fine. Just let us know.
Thank you, Andrew. Okay. All right. Thank you, guys. I think we really appreciate all of the hard work and the collaboration that we've had with PolicyLab around some really great and interesting findings and a challenging finding. So we wanted just to talk about where we're at and what our plans are, and also to enable people to provide some additional input and feedback around what we're doing. So as Meredith and Katie shared, the home visiting is not causing abuse, but children of moms and primary caregivers who are enrolled in home visiting are more likely to visit the emergency room, and that abuse isn't common, but our children are at higher risk. So as we've enrolled more and more families, and we are reaching out to make sure we find families with the most complex needs and the most risk factors, including mental illness, substance use disorder, past involvement with child welfare, we're likely to see an increased risk around abuse and injury. So what can we do? And especially related to alternative caregivers and grandparents. Okay, great. Do the next one. Thanks. All right, so we're going to continue our close working relationship with PolicyLab around the issues, and they've been great partners and helpful strategizing with us. Some of the other things we've done is, of course, our bureau at OCDEL has become the Bureau of Early Intervention Services and Family Support. So now we have infant, toddler, and preschool early intervention, as well as all our MIECHV-funded home visiting programs, plus our expansion that we were able to do this past year. So we have Early Head Start, Healthy Families America, Nurse Family Partnership, Parents as Teachers, and now Family Checkup, as well as the Children's Trust Fund, our fatherhood programs, and our family centers. In addition to all of those, we also have a program called Parent to Parent, so where parents can interact with other parent mentors. We're working closely with the Pennsylvania Family Support Alliance, who is our leader in prevention of abuse and neglect, and the Strengthening Families Leadership Team. We've had some initial stakeholder meetings around preliminary findings. In addition to that, we're revamping our family support strategic planning stakeholder group. Stay tuned to hear more on that. And we have a lot of collaborative efforts going on at a state level with our booster agencies, with our Office of Children, Youth, and Families, through the Child Welfare Council, Alms House, Mental Health and Substance Abuse, Departments of Drug and Alcohol Programs, our opioid task force command center. There's a multidisciplinary work group for infants who are substance exposed, and we also have really close working relationships with education, our ODP partners, developmental programs, as well as grandparents raising grandchildren, and the Pennsylvania Coalition Against Domestic Violence, and the Rape Crisis Centers. So in terms of training strategies, since we have reorganized and become one bureau, we've been able to open up our early intervention technical assistance portal, which has a lot of trainings around children with special health care needs. We've been able to get access for all our home visiting programs, but especially for our NFP program, we've been able to get nursing credits for our Autism Navigator online course. We've had about 180 nurses register. I'm not sure how many have completed the course at this point, but that was really exciting. We've gotten good feedback on that. We've also worked and created a series of webinars for home visitors and the domestic violence staff, and we're expanding that to our early intervention community. The Pennsylvania Coalition Against Domestic Violence presented a 3-part series. Is that on our website?
Some of them are.
Okay, so we'll make sure, we'll check and see if they're up there, and if not, we'll make sure that if we can, we'll put them up there. They were called Working Together, Improving Outcomes for Families Experiencing Domestic Violence. We had an introductory one last July. In September, it was a training for the domestic violence staff around home visiting. And in February, it was defining and recognizing domestic violence and safety planning with families. So we're going to continue that work through our state CQI, and there'll be 3 more webinars in collaboration around intimate partner violence.
The next one's on pregnancy and IPV, and forgive me because I don't remember the date at this point, but it's on pregnancy and IPV, and I'll get the date and make sure for those programs you'll receive information from Ashley and or Heather.
Mm-hmm. Thank you. And one was on drug use and IPV as well. So it's a very hot topic. Okay. The other thing we're in process of now, we reached out to all of our evidence-based home visiting models and asked them to audit their curriculum related to child maltreatment and home visiting, discussions with parents and caregivers related to sensitive subjects around intimate partner violence and child abuse and injury. We've also, we're looking at ways to engage alternative care providers or extended family members in home visiting, so boyfriends, dads, grandparents. We've been very successful in helping our families, especially our moms, in going back to work and going back to school. And so therefore, we have a lot of alternative caregivers who haven't had the opportunity to benefit from home visiting, and so we'd like to extend that given these findings. And a lot of our home visiting programs already do that, so we want to acknowledge that, but we want to expand that as much as we can. And we have one of our home visiting programs that has specifically implemented a mental health curriculum, but we know a lot of others do work around that. So we want to see what already is out there and how we can beef it up or really highlight it so that families know we're having a conversation about abuse and neglect and injury. We're also working, as I said, with the Family Support Alliance, piloting a program called Families in Recovery, which is a parenting group for parents who have a substance use disorder. We're going to pilot that in 16 family centers across the state, targeting the beginning. We'd like to start in October. We're still contacting those programs and working on rolling that out. OCDEL as a whole is looking at access and cost of high-quality infant care, and we are going to have a big focus next fall on infant toddler care and how families can access that. We're very excited about that, as well as we're relooking at all resources that we currently have out there for families around how to select high quality childcare, and we're going to work closely with our early learning resource centers around helping families access subsidy to high quality care. So as we move forward into 1819, we understand that we're doing a lot more around depression screenings, intimate partner screenings. We want to also, besides screening, ensure that those families then can access services and support. And again, that's part of our state continuous quality improvement goals around increasing the referrals and access for service around depression and intimate partner violence, as well as safe sleep. In addition, we're also exploring other evidence-based or evidence-informed curriculums that do focus on abuse and neglect and injury prevention. We've engaged in some preliminary discussions with Safe Care and are exploring ACT through the Family Support Alliance. CHOP PolicyLab has also provided us with some additional programs that we're exploring with with our partners to make sure we can get a wide variety of programs across the state. In addition, we're also collaborating with the Strengthening Families Leadership Team. So we're working with them at doing some basic webinars for all understanding the Strengthening Families protective factors and how all of our family support programs and our early intervention programs can use that in their work with families. We're also exploring how we can expand parent cafes as another model of parent support. And we do have some trainers in Pennsylvania around the parent cafe model. And so we're really looking at expanding that. The other thing we're almost ready to send out is a survey for home visitors and early intervention staff, direct line staff, that would, through a Survey Monkey, go to our grantees to send out to direct line staff training needs around how to support families with complex needs and how we can best deliver those training and technical assistance to our home visitors, whether that's in the form of something like this, a webinar, short kind of job aids or vignettes, and also, some on-site technical assistance around reflective supervision and other tools that we know have been helpful in communicating with families. And lastly, we're going to be doing quite a bit of cross-systems training this year around supporting families with substance use disorders, supporting babies born with neonatal abstinence syndrome, how to have difficult conversations with families, like I said, about abuse and injury prevention, intimate partner violence, and mental health support. And as I said, our continued collaboration with CHOP PolicyLab, as we move forward, we're going to be doing a community needs assessment over the next few years with all of our family support programs with PolicyLab. And we also want to evaluate the strategies that we're putting in place now, the things that I've just talked about, to see what kind of impact we're making and how we can achieve more positive outcomes. So again, as we said, we need your input. I think in terms of responding right now, if there are any questions, please send them in. Otherwise, you can always send any kind of ideas to Andrew directly or to your family support specialist, either Pal or Ashley Ankeny. And as we move forward this year with the cross-systems training, there will be lots of opportunities to let us know what's working, what's not working, and what support you need to better support our families.
There will also be quite a bit of surveys too. So you might be over-surveyed for a little bit, but it's important information to share back with us. Those will primarily come out through Ashley and Heather, just so you're aware. Some of them will be at the administrator's level. Some of them will be for home visitors on down, so they'll indicate which one's which, so you're aware.
Looks like we did get one question or comment. I think it's more of a comment, but resources addressing the misconceptions related to traditional child care centers could help too. Many families report they feel uncomfortable with leaving their child at child care centers and more comfortable with family friends who we know may not be the safest place for their children. Also, more advertising or opportunities to welcome families to tour high-quality child care centers might help.
Yeah, that's a really good comment. Andrew's doing a training in a few weeks with our early learning resource centers, which is one way to reach families. We also have, through our Child Care Development Block Grant, we now are certifying friends and family care. So if a family is able to access subsidy, we do know that lots of infants and toddlers aren't in high-quality child care programs. There's not tons of them, and they're very expensive. So absolutely, we're trying to develop different kinds of ways to reach these families, and absolutely we'll take this into consideration as we work, again, towards improving care for all of our infants and toddlers. We really have focused at OCDEL quite a bit, and rightly so, around preschool initially, and we're really feeling that we need to do more around infants and toddlers. Other questions?
Does not at this time it does not appear to be any additional questions unless you're typing. We'll hang out for another 3 to 5 minutes to make sure there are no other questions that we're missing. If not, then everybody can have a good rest of their week. And again, the recording will be posted to the it's pa-home-visiting.org website, and it'll be under the Provider Resources tab at the top once it's posted. All right, I know I said 3 to 5 minutes, but nobody's typing any additional questions as it appears. So if you have questions, you can always email Ashley and Heather, and they'll get it to the appropriate people. And everybody have a good rest of their week. Thank you.